welcome back to our YouTube channel. My name is Benta Kirubo.
And my name is Debbie Kiboma.
My name is Dr. Bharath VYAS.
Yeah, today we're going to talk about diabetes type 2 treatment goals, and Dr. Bharath VYAS will take us through. Welcome, doctor.
Yeah. See, when it comes to diabetes, especially today we are discussing about type 2 diabetes actually,
Yes.
in specific. In type 2 diabetes, the main goal is to maintain the optimal sugar goals. These optimal sugar goals throughout history have been changing, but for all clinical and practical purposes, we take it that maintaining blood sugar less than 200 milligrams per deciliter or less than 11 millimoles per deciliter as a standard. At any point of time you check, it should be less than 11. There is a lot of debate going on regarding what should be the optimal fasting sugar level, because the guidelines have recently changed. Guidelines have changed in the sense, previously the good sugar control was thought to be less than 7 of HbA1c. Now American Diabetology Association is saying that less than 8 would be a good idea. But then again, it's a academic debate. There are both what you call for people and against people. So there are a clear division. But most of the clinicians tend to go by their personal practice experiences. In my experience, I take less than 200 milligrams per deciliter at any point of time as optimal sugar control, and my HbA1c goal is less than 7 for a type 2 diabetic person. Okay, that is first thing. And second thing is that diabetes itself won't kill anybody. Okay, the complications of diabetes are the ones which kill people. So the prevention of complications, prevention of micro and macro angiopathy. Microangiopathy causes retinopathy, then kidney disease, all these things. Microangiopathy causes your heart attacks and strokes, and microangiopathy also causes peripheral neuropathy. So prevention of these complications, early identification and prevention of the complications. These are the broad goals of diabetes treatment.
Okay, Doc, you spoke about HbA1c.
A1C.
Yeah, can you kindly elaborate a little bit so that our viewers can get what is that?
HbA1c is the definition of diabetes.
Yeah.
Okay. According to all world diabetic societies, HbA1c is the what you call definition of diabetes. The previous days of defining diabetes by postprandial and fasting blood sugar are no longer used because they are not efficient. HbA1c means the percentage of hemoglobin that is glycated. Glycated in the sense when there is too much of sugar in your body. Sugar is nothing but glucose. You see, when this glucose goes and binds to hemoglobin molecule, that's when we get the glycated hemoglobin, and we measure it as a percentage. Okay, and that is actually almost fixed, which means that the reason for it being fixed is that the RBC are produced from your bone marrow and they get destroyed in the spleen. The average span of RBC is around 120 days, that is 4 months. Okay. So at any point of time, at least 3 months is the average RBC lifespan in the body. Okay, and hemoglobin is contained in the RBCs. Okay, so what you are doing is, when you are measuring the glycated hemoglobin, what you are measuring is on an average how is your sugar behaving in the body.
Another question, doctor, that viewers could love to know: at what point, as a doctor, will you put a patient on the diabetes type 2 medication? When do you use, like, is it honest to say we will stick to the HbA1c average report rather than the RBS? Like, if someone does the RBS in the morning, the random blood sugar tests every day, and the fasting blood sugar tests every day, records them, and they are all high, for instance, can they be initiated on medication, or is it a must for the HbA1c average?
Both actually. HbA1c will guide us what is the right medicine, what is the right approach towards the patient. HbA1c is one of those indices which guide us, which guide the treatment principles. Whereas your daily RBS measurements, they will give a good idea where our treatment is heading. Because HbA1c, there is no point in doing HbA1c on a monthly basis because it gives an average of 3 months. Okay? So we cannot do it daily, or we cannot do it weekly, or we cannot even do it on a monthly basis. There are tests available, actually, just like HbA1c. There is a test by name 1,3-anhydroglucitol.
Okay.
This is a test which gives us daily variation in blood pressure. Sorry, blood sugar.
Blood sugar.
How much blood sugar is varying in a day? That we can know through doing 1,3-anhydroglucitol. And there is another test by name fructokinase, serum fructokinase. That gives, serum fructosamine, not kinase. Serum fructosamine, a fair idea of how the blood sugar is behaving in a 15 days time. And there is one more test, albumin bound glucose, which will give us 1 month average. But in the research, what we found is that these are all research tools only. They don't have too much of a practical application. HbA1c is giving a very fair idea about how the diabetes is behaving in a person. Is it controlled or not controlled? Is the patient is likely to develop microvascular and macrovascular complications? All these things we will know through HbA1c. But whereas the others, they don't give that much idea, so we don't do them routinely.
Okay.
Yeah.
Doctor, you can now take us through the treatment goals.
Yeah, treatment goals, as I told you. In this particular session of ours, I would like to discuss the newer drugs.
Okay.
Newer in the sense relatively newer drugs. Actually, we can define the diabetes treatment history before and after these drugs, especially after the research into GLP-1 mechanisms. GLP-1 is the expansion of GLP-1 is glucose dependent insulinotropic polypeptide 1 receptor. This is a very important receptor. Basically, what we have to understand is that there is a fine interplay between insulin and glucagon. These are opposing hormones in the body which regulate our metabolism. Any imbalance in these hormones brings about diabetes. How this imbalance is brought about and what is the mechanism of this imbalance actually defines the diabetes. Okay. So most of the early research in the diabetes happened in the field using insulin and its mechanisms. After the advent of GLP-1 mechanisms, this glucose dependent insulinotropic polypeptide 1 receptor mechanisms, we understood more about glucagon, the role of glucagon in diabetes and control of metabolism. Okay.
Yes.
So by exploiting those newly discovered mechanisms, we are able to control diabetes now more efficiently. In fact, in our own hospital, we had seen patients who had come with HbA1c of 13, 14 like that, and we almost made them normal, less than 7. Even so many, there are patients, I can even remember the names. For the sake of secrecy, I am not revealing, but there are patients for whom we actually stopped diabetes medicines because we were able to regress diabetes. Their HbA1c values became less than 5.5 with efficient treatment, and without previously it was not possible. When we are treating only with insulin, metformin, sulfonylureas, it was not possible because when we go aggressive, patients used to become hypoglycemic and they used to come with lot of complaints. Actually, the number one resistance to taking insulin in diabetic patients is the advent of the incidence of hypoglycemia. Because of hypoglycemia, many patients actually fear diabetes treatment. But now that is not happening because of the advent of these drugs. In fact, after the advent of these drugs, the diabetic history faced a paradigm shift. The way we look at diabetes and diabetes treatment has totally changed. Previously, we used to classify diabetic drugs based on their mechanisms, their glucose lowering capacity, the amount of pleiotropic effects means not only controlling diabetes but also bringing about other useful benefits. That's how we used to look at. But after the advent of these drugs, we are looking at diabetic drugs in terms of are they causing weight gain, are they causing weight loss, are they weight neutral. Okay. The newer drugs, that is DPP4 inhibitors, GLP-1 agonists and SGLT2 inhibitors, all three drugs, they make the person to lose weight through exploiting the glucagon mechanisms.
What if the person is already a low kgs?
I mean,
like maybe 50 kgs.
You mean to say not non-obese?
Yeah.
Non-obese, the way we treat is different. Usually in lean, that's what we call lean diabetics. In lean diabetics, there is more incidence of insulin resistance. That's what I have observed in my practice. But whereas in obese individuals, it is possible to what you call regress diabetes, and in some cases with some special therapies, something like metabolic surgery, it is also possible to cure diabetes. Yeah.
So that is to say diabetes is not a killer disease.
Diabetes is a killer disease when it is not controlled well, but now the technology has advanced so much that you don't need to fear too much about diabetes, and in fact you can regress diabetes. Unfortunately, many medical officers, not only medical officers, even consultants, may not be of medicine, but consultants of other branches of medicine, they don't know about this. Okay. And when we look at these drugs also, first is DPP-4 inhibitors, that is dipeptidyl peptidase inhibitors. In Kenya, we have sitagliptin, saxagliptin, vidagliptin, linagliptin, and recently teneligliptin. Okay, there is a lot of variety here. Actually, now it is possible to tailor make the treatment. You see, for example, we can even now the medicine has become so advanced now that even the side effects we are able to use them as for the beneficial. Okay, so for example, if a patient is having chronic kidney disease and we want to use DPP-4 inhibitors, we can start the patient on linagliptin, which is very safe. Okay, the patient is in all the gliptins, vidagliptin is the drug which has least side effects. That's why we prefer more in this hospital. And also there is cost to benefit ratio. All these things can be analyzed. Not only the health of the patient, even the financial aspects of the patient we can take into consideration, and we can make a tailor-made therapy. For example, the teneligliptin is very cheap, but its glucose lowering capacity is as comparable to as other gliptins. You see, sitagliptin causes acidity in some people, but it can be given in those people who has some digestive problems because of lack of enzymes in the stomach. You see, so that way it can be exploited. Okay. Then comes GLP-1 agonist. There's only one molecule that is available all throughout the world actually. That's dulaglutide. It comes in the name of Trulicity. That injection is available. The only problem is it is slightly costly. Costs around 12,000 shillings. But this is an excellent molecule, especially for those obese diabetics in whom there is a lot of excursions in blood sugar. Excursions means once they are hypoglycemic, once they are hyperglycemic, especially with insulin treatment, their sugars are not getting controlled. These kind of people, when we initiate them, but they have to be obese. When we initiate them on dulaglutide, they start losing weight. The essence of this is it's a once in a week injection. So my approach towards people whom I initiate on dulaglutide is to put them on oral hypoglycemic optimal or maximal dose of oral hypoglycemic agents, and let the sugars not be controlled perfectly. But once we start dulaglutide, they will come into control as they lose weight. In fact, one obese lady had come to us. She lost around 30 kilos. Can you believe that?
Wow. That is good.
She came when she presented, she was 138 kilos, and last visit was 98 kilos.
Wow.
So it is possible, but it may not work in everybody. In whom it works and in whom it doesn't work, that again is a matter of debate. But we have to try. Okay. Then the third one is SGLT2. SGLT2 is sodium glucose cotransporter inhibitor. What it does is it will prevent the reabsorption of sodium from the collecting tubules in the kidney. So the sugar gets excreted through the urine. And because of this, sugar has high osmotic pressure. So it works as a solute and it will take the solvent. That means it will suck away water from the body. So it also helps to lose weight. These class of drugs also. In Kenya we have canagliflozin, dapagliflozin, and empagliflozin. Okay, 3 gliflozins are available in Kenya, but they are slightly costly. But again, cost to benefit ratio can be managed in patients, because usually dulaglutide is slightly cheaper than empa or cana. Cana is the costliest. So we can choose patients according to their paying capacity, their weight reduction effects. But all the gliflozins, again, they are modest in reducing the sugars, but they will give this extra benefit of losing excess weight, which will modulate the physiology in such a way that the diabetes gets controlled. The last lady whom I mentioned, she lost the weight with dulaglutide, and we are maintaining the weight. So the technology has become so advanced now that we can tailor make the treatment. At the end of the day, this is the carry home message. As you asked me, diabetes, is it a deadly disease? It used to be a deadly disease because many people used to die of diabetes. In fact, I lost my dad because of the effects of complications of diabetes. But it is not so anymore. And previously also people used to believe that diabetes could be regressible, but at that time the technology was not there. And actually there are newer medicines. The diabetic research is a continuous process. Even newer medicines are being researched, and a couple of medicines are yet to come into market with very good side effects and use profile. But again, the existing drugs are not so bad off. Yeah.
You spoke about the sodium
glucose co-transporter inhibitor.
Yeah, and then when you were saying that, there was something that came up with the kidney. Like they do not absorb the sodium
from the kidney. What happens is there is something called glomerulus in the kidney, which works like a sieve to filter the harmful molecules, the waste from the body. Okay, once along with that waste, even some useful water and sugar, they are collected into the collecting ducts, which are the what you call, they are present at the end of the glomerulus. Okay, from these collecting ducts, these important molecules which need not be lost, they are reabsorbed back. And this sodium glucose co-transporter inhibitor, it blocks that. The sugar which is filtered in the kidneys, instead of getting reabsorbed, it gets excreted through the urine. Okay. Because of that, there is a very important side effect actually. In males who are uncircumcised, this excess of sugar in the urine causes infection at the end of the shaft of the penis. Even in females who are prone to urinary tract infections, it causes frequent urinary tract infections. That is the reason why we take a very detailed history before initiating SGLT2. No matter how good they are, at the end of the day, there is some side effect. So based on those things, we screen our patients so that we can make the tailor-made treatment.
Okay, and with that, they are safe for the kidneys.
Yeah. There's nothing. They will not harm the kidney unless very serious infection occurs. That's the reason why we are very careful in choosing the patient, in whom to give and whom not to give. Okay. So there's something called balanitis which happens in males. It's actually interesting. When the SGLT2 inhibitors were introduced in the market, all the urologists, they are dead against them because they were afraid of infections. But in my practice, what I have seen is usually urinary tract infections are more common in females than males because of the short urethra. But SGLT2 inhibitor induced urinary tract infection appears to be more in males. I don't know why, but it is more in people who are uncircumcised. People who are circumcised, it is not happening. So it may be because of the built up of spengma around the penile shaft.
We thank you. Thank you, and for that, maybe you can give a remark on people living with diabetes.
As I told you already, there is beautiful technology available nowadays. No need to be worried of. Only thing is that you need a well-trained doctor to control your sugars, and it is possible to induce remission in at least a select population of diabetic people. If not everybody, people who are obese especially, if they follow a good lifestyle and use medicines well, it is possible to regress diabetes. And especially people who are morbidly obese, it is even possible to cure diabetes in them by subjecting them to metabolic surgery.
Thank you. Thank you, doctor, for the good information. And thank you, our viewers.
Bye.
Bye.